Welcome to Labor at Risk. The content of this lecture is taken from ATI Chapter 16, and this is actually my favorite type of nursing care to provide. So the first thing we have to do is just remember some intrapartum procedures. So you'll be expected to apply external fetal monitors. You might have to listen for fetal heart tones with the Doppler, assist with the application of any internal fetal monitors like the fetal scalp electrode or the intrauterine pressure catheter. You may be asked to assist with amniotomy, that's artificial rupture of membranes, amnioinfusion, which is done through an IUPC, intrauterine pressure catheter, to instill fluid back up into the uterine cavity. And you may need to support the laboring mother during an epidural insertion. The first complication that I want to talk about today is a prolapsed umbilical cord. And that's when the umbilical cord comes before the presenting part. And I hope you remember from an earlier lecture that when the umbilical cord gets pinched, the baby doesn't get oxygen, and you'll notice a decrease in the baby's heart rate. That's why it's so important to assess for fetal heart rate right after rupture of membranes, ROM, whether it's spontaneous, SROM, or artificial, AROM, or amniotomy. Also, babies that have an abnormal presenting part, they're also at risk for prolapsed umbilical cord. And that's because there's a smaller part and they're not filling the pelvis. So usually the baby's head is the biggest part of the baby's body. It fills the pelvis and it doesn't allow that umbilical cord to slip past it and prolapse. If you have feet that are coming first, or a buttocks or a shoulder that's coming first, they're all abnormal and they have a greater risk for that umbilical cord prolapse. Babies that are small, they're not as big. They don't fill the pelvis as much. Babies that have a long umbilical cord, there's more to prolapse. Multiple gestation, pretty much because there's more cords, and there's also a higher incidence of an abnormal presenting part. And then the last one is polyhydramnios. Poly means a lot, and hydramnios is the fluid. Sometimes you might just hear hydramnios, and that means polyhydramnios. So lots and lots of fluid, and if the fluid leaks or the mom's membranes rupture, that cord can prolapse. So the most important thing, remember your ABCs. The mom's probably going to be okay, but we have to remember the baby's ABCs. Well, right now the baby doesn't have an airway and they're not breathing, but we need to restore circulation and we need to get this baby out fast. So you need to call for help from the room. Don't leave the patient. And you'll want to elevate the presenting part off of the cord. And that means putting your fingers in the woman's vagina and feeling the presenting part and pushing it up off the cord. And if you're the one that discovers the umbilical cord prolapse, you will keep that presenting part off of the cord until the baby is delivered by stat C-section. You can also reposition the mom. Remember that gravity is a great thing to help us out. So if she's able, you can ask her to flip over onto hands and knees and put her chest down onto the bed and her butt up in the air. Hopefully that'll slide the baby off the cord, but you still want to keep your fingers on that presenting part and off the cord. If the cord prolapses out of the vagina, you want to keep it moist. So warm, sterile gauze saline. EFM means electronic fetal monitoring. You will need to prepare this or your coworkers, because you're busy holding the presenting part off of the cord, you will want to make sure this patient is prepared for stat C-section. And then this is an emergency. This is a dire emergency. If the baby is on that cord for too long, it's going to die. So we need to work quickly, and usually the OB teams do that. We also need to remember the family and the woman, the birthing person, and we need to provide emotional support in a calm and slowly, so they understand, so that we don't elevate their anxiety unnecessarily. Meconium stained fluid. I know I talked about this with the newborn, with complications with the newborn, and here it is. Meconium is just that first stool, and it's passed before the baby's born. So it's passed into the amniotic fluid. We know that the meconium's in that amniotic fluid if the mom has ruptured membranes and that fluid is green. Might be greenish fluid. It could be greenish fluid with dark flecks in it, like pieces of meconium. That's all important to note when you do your documentation. This happens more at later gestational ages, especially toward that late term or post-term pregnancy. Remember, because the placenta doesn't work as well, the baby's not as oxygenated, and fetal hypoxia can lead to meconium passage. So you'll note it when there's rupture of membranes. So remember to document TACO, time, amount, color, and odor. You'll want to notify the neonatal team, because this is important for the OB provider as well as the neonatal provider to know. These babies, because we know meconium is passed due to possible fetal hypoxia, this baby may need resuscitation after delivery. So for every delivery, we want to make sure resuscitation equipment is gathered, but especially in meconium stained fluid. And then once the baby's born, if they need resuscitation, you as the nurse would participate in that resuscitation effort. Fetal distress. And we did fetal heart rate tracings a few weeks ago. Abnormalities in the fetal heart rate tracing might be greater than 160, which is tachycardia, could be bradycardia, it could be decreased or no variability, that's that wiggliness of the baseline, and that means that there could be some hypoxemia going on, or acidemia, or hypoxia, or asphyxia. Decreased fetal movement could also be an indication of fetal distress. Remember, when you're sick, you don't want to move. When babies are sick, they don't want to move. Another indication of fetal distress could be recurrent variable decelerations or recurrent late decelerations. So as the nurse, we'd want to continue to do vital sign monitoring, both of the mom and electronic fetal monitoring of the fetus. We should be trying maternal position changes to either float the cord off of the presenting part, to make sure that we alleviate the cord compression, or to try to increase the perfusion of the uterus and the placenta. If the baby, if the mommy is being administered oxytocin, we want to turn it off, because those contractions that are stimulated by oxytocin, every time there's a contraction, the baby doesn't get oxygen. If need be, we need to administer a tocolytic, and the tocolytic of choice usually is terbutaline, and I believe I had you profile terbutaline in your labor complications medication sheet. You can also administer an IV fluid bolus. This is usually part of the standing orders for admission to the labor room. IV fluid bolus just increases the circulating volume for the mom and hopefully improves the perfusion of the uterus and the placenta. If fetal distress is profound and prolonged, as the nurse, you would want to begin preparing for that imminent delivery. And of course, if you see fetal distress on the fetal monitor, you would notify your provider right away. Dystocia. Dystocia is a dysfunctional labor pattern. So on the left-hand side are those maternal factors. We already talked about CPD, which is about halfway down. I want to talk a little bit about uterine anomalies. Some women are born with different uterine anomalies. It could be fibroids. It could be a bicornate uterus. Usually the uterus looks like a pear, but sometimes women their uterus develops like two horns, and there might be a septum in the middle of the uterus. Sometimes it's just one horn of a uterus. So any of those uterine abnormalities can cause dystocia. Babies that are not in the right position or that are too big, more than one baby inside, all of those things can cause that dysfunctional labor pattern. Hypo or hypertonic uterus just means low tone or too much tone. So the uterus isn't contracting hard enough, or it's contracting too much. Sometimes fatigue, maternal fatigue for a long labor, can result in a dysfunctional labor pattern. Fear, we talked about that in one of the first lectures. Dehydration, and also anesthesia, like epidural anesthesia, can cause some dysfunctional labor patterns. So as the nurse, you would want to continuously monitor the patient. You want to monitor the fetus and the contractions. Keep the mom's bladder empty. A full bladder can inhibit the descent of that presenting part. Assist with procedures, and you may be ordered to administer oxytocin, which is that same medicine that we would administer to induce labor. We may have to administer oxytocin to help a dysfunctional labor pattern. Changing maternal positions can result in fetal position changes as well as better perfusion for the uterus. So ambulation, if it's indicated, pain management, because fear and pain can affect that labor pattern. And then we could also prepare for delivery interventions. Before we get to delivery interventions, though, we'll talk about shoulder dystocia, and that's when the baby's shoulders get stuck after the head is delivered. You can see the risk factors on the left-hand side of the slide, and I want you to note the nursing care for shoulder dystocia. First, you'll want to make sure that there's continuous fetal monitoring. Second, the provider will probably say McRoberts maneuver or get her legs back. So the graphic underneath on the left-hand side is flexing those hips back toward the maternal abdomen, and you'll also want to lower the head of the bed so that the woman is flat. That McRoberts maneuver with flexing the hips back and lowering the head of the bed is most of the time changes the angles of the baby's shoulders and the maternal pelvis enough to get the baby's shoulders delivered. If that doesn't work, the provider will ask you to do suprapubic pressure, and that's just trying to reduce the diameter of the baby's shoulders, or to be able to push the baby's shoulders to a more oblique position where there's a wider diameter. So there will be a question on shoulder dystocia on the exam, The first maneuver is McRoberts, and the second maneuver is suprapubic pressure. The next labor complication is a precipitous labor, and that's a labor lasting less than 3 hours. You can see the risk factors on the left-hand side of the slide. The important thing to do is to stay with the patient. Things are moving very quickly, and you don't want a baby to be born without anyone there. So you stay with the patient and you call for help from the room. You want to provide a lot of emotional support. This is scary. Don't try to stop the delivery, but if the provider isn't there, try to control the rapid descent of the presenting part. Rapid descent can lead to some genital trauma. After the baby's head is born, you want to put your fingers around the neck and check for the cord. You want to suction the newborn and then make sure you deliver the shoulders and the rest of the body. Because of the rapid delivery, lacerations are possible, and you'd want to monitor for postpartum hemorrhage. Babies could be at risk for hypoxia due to a hypertonic uterus, and also intracranial hemorrhage because of that rapid descent. So just things to be aware of for that newborn too. The next complication of labor is uterine rupture. So that's when the uterus itself actually tears open, and it can happen before the baby's born. So part of the baby might be protruding through the wall of the uterus. So you can read through the risk factors on the left-hand side. Overdistension could be due to multiple pregnancy or because of a macrosomia or polyhydramnios. Also, you want to look at prior surgeries on the uterus or any uterine abnormalities. That puts a mom at higher risk for uterine rupture. So nursing care, what you'll probably see on the fetal monitor is abnormal tracing, fetal tracing. You may see changes in vital signs of the mom. Moms may complain of pain or tearing. This requires immediate delivery by stat C-section. And if that rupture is big enough, the woman may require a hysterectomy. So providing lots and lots of emotional support. Babies that rupture through the uterus, they may have some fetal distress, and we want to notify the neonatal team because these babies may need some resuscitation. Amniotic fluid embolism, and some people call it anaphylactoid syndrome of pregnancy. And this phenomenon is not really well understood. What's thought to happen is that some amniotic fluid gets into the maternal circulation, and that's what a fluid embolism is. Women that have an amniotic fluid embolism, usually they sit up from laboring and they say they can't breathe, and they are panicked because they can't breathe. So you will do a good nursing assessment, and you'll find an alteration in vital signs, including a low SaO2. So you'll provide oxygen by non-rebreather mask at 8 to 10 liters per minute. These moms will probably need intubation because their respiratory system is going to crash. You may have to provide cardiopulmonary resuscitation because once their respiratory system crashes, then so will their cardiac system. You'll want to administer IV fluids, maybe blood. You'll need to do an accurate INO with an indwelling urinary catheter. And if the mom hasn't delivered yet, she will be taken for stat C-section. Every once in a while, an amniotic fluid embolism can happen even right after delivery. So just be aware of those symptoms. All right, so sometimes with dystocia, you may need to assist with an instrumented delivery. And the instruments that are used are vacuum and forceps, and we talked about these a few weeks ago when we talked about delivery. If the mom has had a very, very long, prolonged labor, first stage, second stage labor, she may be so exhausted that she just cannot push anymore. And that's when the provider would offer to do vacuum or forceps. So as the nurse, when a vacuum or forceps is used, as the postpartum nurse, you would want to just be aware and be more vigilant about bleeding, because these can cause genital trauma leading to hemorrhage. They can also be cause tissue trauma or birth trauma to the newborn. And this is just a slide that has a picture of what a set of forceps looks like on the left-hand side, how it fits around the baby's head in the middle picture, and then that little bruise on the baby's cheek is what could happen as a result of forceps delivery. Surgical delivery or cesarean section, you can read the risk factors on the left-hand side. We would want to do good pre-op care and teaching. We would want to prevent complications, so applying sequential compression devices to the legs. These women also have indwelling urinary catheters to keep their bladder empty to minimize the risk of trauma during the surgery. And then we'd also provide good post-op care and teaching. And last is intrauterine fetal demise. And on the last slide deck, we talked about perinatal loss. So I'm not going to really beat on this one too much. Stillborns do happen, and we need to provide good emotional support along with good physical care for these grieving families so that we can assist them in that grieving process. And then also provide referrals. There are many support groups out in the community for families experiencing loss. So just good to know to be able to pass on to those families.